Hi rabbits, Research Turtle here. Today, we are diving deep into a critical shift in cardiovascular medicine. We're looking at the NSTEMI-HFpEF Continuum. For a long time, we've treated NSTEMI as an acute event, a plumbing problem to fix. But the data tells a different story. NSTEMI isn't just a heart attack, it is the primary gateway to heart failure with preserved ejection fraction, or HFpEF. We need to stop just opening vessels and start preserving hemodynamics. Let's look at the numbers. This graph shows the paradox of survival. The red line shows acute mortality dropping significantly over the last 30 years, thanks to primary PCI and better drugs. We are saving the muscle. But look at the blue line. Heart failure morbidity is skyrocketing. Patients are surviving the acute event, but they are living long enough to develop chronic structural heart disease. Essentially, our success in saving lives has birthed a new challenge, a massive rise in chronic heart failure. We need to understand why the disease profile is changing. In the past, we dealt with STEMI, that's the image on top, big plaque ruptures, full wall necrosis, leading to pump failure, or HFrEF. But today, the dominant player is NSTEMI, the image below. These patients are older, diabetic, and hypertensive. They don't have massive scarring, they have partial subendocardial damage. This doesn't make the heart weak, it makes it stiff. Why does this matter right now? Because NSTEMI is a leading indicator. Projections show a 46% increase in heart failure cases by 2030. The blue bars, HFrEF, are stable. The red bars, HFpEF, are exploding. Current NSTEMI spikes are the canary in the coal mine. The acute events we see today will manifest as the chronic failure surge of the next decade. It turns out the NSTEMI patient and the HFpEF patient are actually the same person. Look at this Venn diagram. Both groups share the exact same risk profile: advanced age, hypertension, obesity, and systemic inflammation. While STEMI has higher hospital mortality, NSTEMI actually has higher long-term mortality because of this heavy comorbid burden. This overlap is most dangerous in women. Female hearts respond differently to injury. Instead of dilating like a male heart often does, a female heart tends to stiffen. Women are also more likely to present with MINOCA, myocardial infarction with non-obstructive coronary arteries. They don't have a big clot, but they have significant ischemic injury, leading to concentric remodeling. This makes HFpEF a female-dominant failure mode. Let's get into the mechanism. Why does NSTEMI cause stiffness? It's about the subendocardium, the inner layer of the heart. This layer is responsible for the active relaxation of the ventricle. It is incredibly energy hungry. When ischemia hits, ATP is depleted here first. Without ATP, the heart muscle literally cannot let go. The contraction remains normal, so the ejection fraction looks fine, but the relaxation fails. This is diastolic stunning, and it spikes the pressure inside the heart. Connecting all of this is coronary microvascular dysfunction, or CMD. Think of this as the common soil. Even if the main arteries are open, the tiny vessels are failing due to diabetes or hypertension. This causes chronic low-grade ischemia that leads to fibrosis. It's a vicious cycle. High pressure compresses the microvessels, which causes more ischemia, which causes more stiffness. At the molecular level, we have a problem with titin. Titin is the molecular spring of the heart muscle. In NSTEMI and HFpEF patients, systemic inflammation stops the proper signaling, specifically the nitric oxide pathway. This causes titin to become physically stiffer. So even without a scar, the heart muscle becomes like a stiff rubber band rather than a flexible one. Now, here's the problem for interventional cardiologists. We call it the oculostenotic reflex. In the cath lab, we treat what we see. If the angiogram shows open arteries, like in Myocardial patients, we reassure them and send them home. But we are missing the invisible killer. We are missing the high filling pressures and the microvascular dysfunction hiding underneath. The most overlooked tool we have is LVEDP, left ventricular end diastolic pressure. Look at these survival curves. If a patient's LVEDP is over 19 millimeters during an NSTEMI, their long-term survival drops significantly. This is the warning shot. It's the most accurate assessment of stiffness we have, yet it is often ignored if the arteries look clean. Why do we miss this? First, diagnosing HFpEF is complex. It's not as simple as checking an EF number. Second, workflow. Measuring pressures takes time in a busy lab. And third, historical nihilism. We used to think HFpEF had no treatment, but that is false now. With SGLT2 inhibitors, a diagnosis changes everything. So here is the proposed protocol. If you are in the cath lab and see non-obstructive disease, Myocardial, you must measure LVEDP immediately. If it is greater than 15 millimeters, that is a red flag. That patient is in a pre-HFpEF state. You cannot just discharge them with standard care. We need to shift the intervention to day 0, right there on the table. If pressures are high, initiate SGLT2 inhibitors and consider MRAs before they even leave the hospital. Treat the dyspnea as a cardiac issue, not just as deconditioning. This prevents the revolving door of readmissions later. To wrap up, the future of interventional cardiology isn't just about plumbing, it's about physiology. NSTEMI is the gateway to the HFpEF epidemic. By detecting elevated pressures early and treating the underlying stiffness, we can stop the progression from acute ischemia to chronic failure. It's time to move from being Lumenologists to Hemodynamicists. That's it for today. Turtle out.